In this lecture, we will talk about malnutrition. The learning objective of this lecture to define malnutrition and know its causes, to assess malnutrition by using the indicators and anthropometric measures, to know the Wellcome classification, to differentiate between marasmus and kwashiorkor, to understand the basics of treatment of severe malnutrition. Malnutrition essentially means bad nourishment. It concerns not enough as well as too much food, the wrong types of food, or the inability to use nutrients properly to maintain health. The WHO cites malnutrition as the greatest single threat to the world's public health. Malnutrition in all its forms is considerable public health concern and is associated with increased risk of disease and early death. Malnutrition is a general term for the medical condition caused by an improper or insufficient diet, undernutrition, deficiency of one or more essential nutrients, resulting from inadequate consumption, poor absorption, or excessive loss of nutrients, overnutrition, and excess of nutrient or nutrients, resulting from overeating or excessive intake of specific nutrients. Structural and functional changes due to inadequate intake of nutrient and energy sources. Deficiency of a single nutrient is an example of undernutrition. For example, iron and iodine. All children with protein energy malnutrition have micronutrient deficiency. Primary malnutrition resulting from inadequate food intake, while secondary malnutrition resulting from increased nutrient needs, decreased nutrient absorption, and/or increased nutrient losses. In developing countries, primary malnutrition more than secondary malnutrition, while in developed countries, secondary malnutrition more than primary malnutrition. Well, when we are talking about Iraq, if we see this malnutrition hotspot all over the world, in 2005, about 4 to 10% of Iraqi people suffering from malnutrition. This is by WHO. Between 2011 to 2013, about 25 to 34% of the Iraqi population suffering from malnutrition. This is by Food and Agriculture Organization, FAO. By 2019, still we are suffering from moderate malnutrition. 10 to 20% of Iraqi people suffer from malnutrition. Causes of primary malnutrition accounts for the vast majority of cases. Nutrition, inadequate food intake due to insufficient or inappropriate food supplies, early cessation of breastfeeding, cultural and religious food customs in some areas. Causes of secondary malnutrition. Children with chronic illness are at risk for nutritional problems for several reasons, including the following: anorexia, which leads to inadequate food intake. Increased inflammatory burden and increased metabolic demands can increase caloric need. Any chronic illness that involve the liver or small bowel affect nutrition adversely by impairing digestive and absorptive function like cystic fibrosis, chronic renal failure, childhood malignancy, congenital heart disease, neuromuscular disease, chronic inflammatory bowel diseases. The term protein energy malnutrition applies to a group of related disorders that include marasmus, kwashiorkor, and intermediate state of marasmus, kwashiorkor. The distinction between the two forms of protein energy malnutrition is based on the presence or absence of edema. Marasmus, it is inadequate intake of protein and calories with absence of edema, while kwashiorkor, fair to normal calorie intake with inadequate protein intake. So we will have edema. When we look to this diagram, the classic history of protein energy malnutrition, usually kwashiorkor starting since the age of 12 months, when with a patient presented with late gradual weaning then they will introduce starchy family diet. He will develop repeated acute infection, then he will develop kwashiorkor at about 18 months. Within 6 months, he will develop his condition. While in case of marasmus, usually it starts from the age of 5 months due to early abrupt weaning, and that will lead to dilute dirty formula, and repeated infection will be developed, especially gastroenteritis, starvation, and the patient will develop nutritional marasmus at 8 months. That's mean within 3 months the patient will develop his condition. And marasmic kwashiorkor develop and usually develop between two conditions. The clinical effects of malnutrition include all aspects of the body: psychology, depression and apathy, immunity, increased risk of infection, decreased cardiac output, renal function. There will be loss of ability to secrete sodium and water. The patient may develop hypothermia, loss of strength, anorexia, impaired gut integrity and immunity, impaired wound healing, liver fatty changes, functional decline, necrosis, and fibrosis. Ventilation, there will be loss of muscle and hypoxic responses. Measuring malnutrition. Malnutrition is assessed by a combination of clinical features and anthropometry body measurements. The indicators used are wasting, which is measured by weight for height, mid-upper arm circumference, body mass index; stunting, measured by height for age; wasting and stunting combined by weight for age. Underweight, measurement that fall below 2 standard deviations under the normal weight for age, while stunting measurement that fall below 2 standard deviations below height for age. Wasting, it is measurement that fall below 2 standard deviations below weight for height. Well, when we look to those three children, the first one, if we ask ourselves the question, is he wasted? Is he stunted? Is he underweight? No, he is not wasted, not stunted, not underweight. While the second one, he is wasted, but he is not stunted, but underweight. While the third one, he is not wasted, but he is stunted and he is underweight. By this simple measure, we can measure mid-upper arm circumference. As we see in this diagram, there is not much difference about mid-upper arm circumference between the age from 1 year to the 5 year, and this is the most common age that affect children about malnutrition. So when the mid-upper arm circumference more than 13.5, we are in the green zone, while when the patient with mid-upper arm circumference between 12.5 to 13.5 centimeter, that's mean the patient with moderate malnutrition. If the patient has mid-upper arm circumference less than 12.5, he is in red zone. That's mean he has severe malnutrition. While if he has mid-upper arm circumference less than 11 centimeter, he has very severe malnutrition. In case of acute malnutrition, the patient will develop wasting, low weight for age, while in chronic malnutrition, the patient will develop stunting, low height for age. As we see, different cases of malnutrition, patient with edema, pitting edema, and in this patient, looks marasmic and emaciated. Welcome classification. We should know about this classification because it is very important. When the weight of the patient, regarding the weight for age, it is 60 to 80%, and the patient has no edema, so he is undernourished. But if he has edema, he is with the kwashiorkor. When the patient with body weight less than 60% of for his age, if he ha, if he has edema, so he has marasmic kwashiorkor. But if he has no edema, so he is with marasmus. So, marasmus, weight less than 60% of expected weight with no edema, while kwashiorkor, weight between 60 to 80% of expected weight plus edema. So, in summary, when the patient has no edema and his weight less than 80%, he is underweight for age. And if his weight less than 60%, he is marasmic. While the patient with edema, if his weight less than 80%, he is with kwashiorkor. If his weight less than 60%, he is marasmic kwashiorkor. If we look for those three children, as we see the chart of their growth, in the first one, good, means the child is growing well, while in the second one, danger, because his growth is stationary, while the third one, very dangerous, may be very ill, need extra care because his growth chart dropping down. What do we need? Scale, our finger, and chart. That's all. That's all to assess the nutritional status of the patient. In case of kwashiorkor, kwashiorkor means the one who is displaced, reflecting the development of the condition in the older child who has been weaned from the breast once a new sibling is born. Jamaican pediatrician Dr. Cicely Williams introduced the name into the medical community in her 1935 Lancet article. The name is derived from the Ga language of coastal Ghana. Kwashiorkor is a deficiency of protein with relatively adequate energy intake. The patient will develop failure of growth. Edema, usually it is spitting, bilateral, including lower extremities, may be localized or extensive, including eyelids. The muscles are wasted. This is a particular noticeable around the chest and the upper arm. The wasting of the legs and around the hips is frequently concealed by edema. Mental changes. The child is apathetic and miserable. Hair become fine, straight, and often sparse. Children with long, straight black hair may show a pale band across the hair, corresponding to an earlier episode of kwashiorkor, the flag sign. Skin. The patient develop pigmentation, discoloration, mucous membranes, angular stomatitis, chylosis, and a smooth tongue are commonly seen, as is ulceration around the anus. Liver, this may be enlarged. Gastrointestinal system, anorexia is usually present, and sometimes vomiting. There is nearly always diarrhea, with the passage of stool containing undigested food. The diarrhea may be due to impaired secretion of digestive enzyme to intestinal mucosal atrophy or to an intestinal infection. Anemia, associated vitamin deficiency, vitamin A, thiamine, niacin, folate, and vitamin K. So the patient with a kwashiorkor have sparse, straight, readily pluckable hair, puffy eyes, moon face, apathy, misery, anorexia, anemia, wasting, upper arms and upper trunk, hepatomegaly, edema of lower arms and legs and lower trunk, crazy paving scaly skin rash with area of depigmentation, ulceration on lower limbs. So this is another diagram. Signs of a kwashiorkor: edema of the legs and arms and face, moon face, moderately low weight, misery and apathy, poor appetite, pale, thin, peeling skin, pale sparse hair with weak root, enlarged liver. Also, this is another photo for patient with the kwashiorkor, edema and skin lesion in a 3-year-old child with kwashiorkor. As you see, it's very clear his edema. Also, another photos for patient with skin changes in kwashiorkor. Nutritional marasmus. due to severe and prolonged restriction of all food, for example, energy sources and other nutrients, plus protein. The two constant features of marasmus are retardation of growth and reduction of weight, wasting of muscle, and loss of subcutaneous fat started from the abdominal wall, then the buttocks, then from the buccal pad of fat, which give the infant a wizened old appearance. Appetite is usually preserved or enhanced. The liver is usually normal with no fatty infiltration. Episodes of hypothermia and fasting hypoglycemia are common. Emaciated, thin, flaccid skin, the little old man appearance, fat and muscle tissue grossly reduced, prominence spine and ribs, behavior alert and irritable, electrolyte imbalance, dehydration, infection, the patient with normal hair. There are no biochemical or hematological changes diagnostic of the condition. Extremely low, the patient will present with extremely low weight, extreme wasting, an old person's face, pot belly, the child's abdomen protruded because the muscles of the abdomen wall are wasted and weak, irritability, and hunger. Weight of the patient less than 60% of expected weight, no edema, often stunted, hungry, relatively easier to feed. This is another photo for patient with marasmus, severe wasting. Marasmic kwashiorkor. Marasmic kwashiorkor, the wasting in the upper arms, characteristic of a kwashiorkor in the lower limbs, as we see oedema in the lower limbs. Also, here we see normal person, wasted, stunted, wasted and stunted patient. Another photo for patient with malnutrition, kwashiorkor, and marasmus. Also, we have a quiz. Patient number 1, patient number 2, patient number 3. It is clear. Patient number 1 with marasmic kwashiorkor, patient number 2 with kwashiorkor, patient number 3 with marasmus. Practical nutritional assessment. Complete history, including a detailed dietary history. Growth measurements include weight and length or height, head circumference in children younger than 3 years. Complete physical examination. Laboratory investigations are generally unhelpful. Tests that may be useful in the assessment of protein energy malnutrition and management of complications. Laboratory studies evaluating protein status, hematological studies, blood glucose, general urine examination and culture, stool exam and culture, chest X-ray. Successful management of malnutrition should mean complete catch-up followed by sustained normal growth, health and development. So the treatment of severe malnutrition, we should have monitoring of weight, height, edema, vomiting, diarrhea, temperature, heart rate, and respiratory. Phases of treatment. Initial or stabilization phase. Management of severe malnutrition is best divided into 3 phases. Following clinical evaluation, the initial phase, from day 1 to 7, involves resuscitation, treatment of infection, and correction of disordered metabolism. The principal tasks are to treat or prevent hypoglycemia, which is less than 3 millimole per liter or less than 54 milligram per deciliter, and hypothermia by auxiliary temperature less than 35 centigrade or rectal temperature less than 35.5 centigrade. Usually occurs together, hypoglycemia and hypothermia. To treat or prevent dehydration and restore electrolyte balance, to treat septic shock if present, to start to feed the child, to treat infection, to identify and treat any other problems including vitamin deficiency, severe anemia, and heart failure. At each feed, the food should be offered by mouth, after which the remainder is given by NG tube. Severely malnourished patients do not tolerate the usual amount of dietary protein, fat, and sodium and require a diet low in these components and in osmolality but high in carbohydrate. The response, usually within a week, the recovery is heralded by the following criteria: eating well, mental status has improved, smiles, respond to stimuli, interested in surrounding, normal temperature, usually 36.5 to 37.5 centigrade, no vomiting or diarrhea, no edema, gaining weight more than 5 grams per kg of body weight per day for 3 successive days. The second phase, rehabilitation phase, usually it is from 2 to 6 weeks. The principal tasks are to encourage the child to eat as much as possible, to reinitiate and or encourage breastfeeding as necessary, to stimulate emotional and physical development, and to prepare the mother to continue to look after the child after discharge. At this stage, the formula feed is changed to one that provides more energy, 150 to 220 kilocalorie per kg per day, and protein, about 4 grams per kg per 24 hour for growth. The child's dietary intake increases steadily. The frequency of feeding is reduced and weight gain is rapid, up to 20 times normal, on average 10 grams per kg per day. The child's mother must be taught of nutrition and food preparation and hygiene. Follow-up phase, this is the third phase, from week 7 to 26 week. Ideally, the child is visited at increasing intervals for up to 3 years to ensure that recurrence of malnutrition is. Follow WHO guidelines. Treat and prevent hypoglycemia, treat and prevent hypothermia, treat and prevent dehydration, correct electrolyte imbalance, treat and prevent infection, correct micronutrient deficiencies, initiate refeeding, facilitate catch-up growth, provide sensory stimulation and emotional support, prepare for follow-up after recovery. Time frame for the management of a child with severe malnutrition. As we see from the start, the first thing, hypoglycemia, hyperthermia, dehydration should be treated in the initial phase. Correction of electrolyte and imbalance, and usually it is may lasting for longer period. Treat infection starting from the start. Correct macronutrient deficiency, usually started from the start but without iron, but after the day day 7, we will add iron. Begin feeding also from the start. Increase feeding to recovery lost weight, catch up growth. Usually this started in the second stage after the first week. Stimulate emotional and sensorial development from the start. Prepare for discharge. Usually we can start from the second stage. This is the same thing. Also, we can see the catch up growth when it is well or bad. Also, this is another example. Complications. Severe kwashiorkor and marasmus has a mortality of around 20% even in a well-equipped hospital. Most deaths occur in the first 10 days. The usual cause of death are intercurrent infection and severe malnutrition. Criteria for discharge before full recovery: when the age more than 12 months or older, antibiotic treatment completed, good appetite, good weight gain, no edema, potassium, magnesium, mineral supplement, and vitamin supplement taken for 2 weeks, mother or caretaker is not employed outside the home, has received specific training on appropriate feeding, has the financial resource to feed the child, and is motivated to follow the advice given. Direct causes of death: hypoglycemia, hypothermia, dehydration, infection, and severe anemia. Prognosis: the sick children usually do not achieve their full growth potential or regain cognitive deficit. Over half of childhood mortality in developing countries is either directly or indirectly secondary to malnutrition. In summary, malnutrition essentially means bad nourishment. It concerns not enough as well as too much food. Primary malnutrition result from inadequate food intake, secondary malnutrition resulting from increased nutrient needs, decreased nutrient absorption, and or increased nutrient losses. Welcome classification. In marasmus, inadequate intake of protein and calories, so we have absence of edema, while in kwashiorkor, fair to normal calorie intake with inadequate protein intake, the patient will develop edema. In the treatment of severe malnutrition, we should have monitoring of weight, height, edema, vomiting, diarrhea, temperature, heart rate, and respiratory rate. Direct cause of death: hypoglycemia, hypothermia, dehydration, infection, and severe anemia.